Well, I'm Scott. We didn't have any disclosures to report. In background, the role of the robotic platform is being scrutinized, hotly debated. A lot of those talks have been happening here during this conference. Robotic colorectal procedures potentially have decreased rates of conversion. That's what some meta-analyses have shown, and decreased time to return a bowel function, but comes at an increased cost. The robotic impact on oncologic outcomes is unclear, and this is important as several randomized trials have recently shown that laparoscopic lower anterior sections are not non-inferior to open low anterior sections. The robotic platform is best studied in low anterior sections, and it's unclear the impact the robotic platform has on other colorectal procedures. So we looked to study 30-day outcomes between robotic and laparoscopic colectomy in a nationally representative sample to determine if there was any, differences based on the site of colectomy. We used a targeted colectomy NISQIP data set from 2012 to 2014, looking at all patients undergoing colorectal procedures with anastomoses. We excluded emergent colectomies, ASA classes of 5, preoperative wound infections, ventilation requirements, or sepsis, and procedures on hospital day greater than 0 to try to only be looking at apples-to-apples elective procedures. We looked at 30-day overall morbidity, mortality. We performed some bivariate data analysis and then built multivariable logistic regression models to control for differences between the groups. And as mentioned, we looked at LARs, left colectomies, and right colectomies separately, given interaction between the groups. So in those 3 years in this data set, there's 64,000 colectomies or so, 30,000 of which were excluded as no anastomosis was performed or they were performed open. With our exclusion criteria, we excluded an additional 6,900, which gave us this breakdown of cases. Namely, amongst LARs, we had 7,400 laparoscopic cases and 807 robotic cases, 12,000 laparoscopic left colectomies and 418 robotic, and 6,500 laparoscopic right colectomies and 260 robotic. There's going to be a lot of data, and I'll do my best to summarize it as efficiently as possible here. These are just some baseline demographic differences, and I'm not going to delve too much into that, but those were controlled for in our models. These are all the comorbidities that we looked at, and what I want to highlight is among LARs, we note that the preoperative chemotherapy rate among robotic LARs was significantly higher. Among left colectomies, the metastatic disease rate was higher in laparoscopic colectomies, and there were some differences in some of the other comorbidities in right colectomies. When we look at the operative characteristics, that difference in preoperative chemotherapy rate makes sense when we look at LARs, which had about a 10 percentage point higher rate of cancer. Now, robotic LARs also had about a 13 percentage point higher rate of diverting ostomy formation. There was a trend towards higher ostomies in left colectomies, and actually an inverse relationship in the rate of cancer diagnosis in left colectomies. When we look at all of our outcomes, so first looking at mortality, there's no difference in mortality in any of the groups. No difference in morbidity, although a trend towards decreased morbidity in robotic left colectomies. No difference in serious morbidity. When you look at conversion rates, it was almost 6 percentage points lower amongst robotic LARs compared to laparoscopic LARs. No difference in left colectomies, and about 4 percentage point lower in robotic right colectomies, which is interesting. No difference in anastomotic leak rates. No a difference in postoperative sepsis, a decrease amongst robotic LARs, and no difference in the other groups. No difference in postoperative ileus. The median operative time was about 40 minutes longer on average across all the groups. The median length of stay in robotic LARs and left colectomies was the same as in the laparoscopic groups, although the mean was lower, but with our skewness in our data and non-normal distribution, we decided to display the median data. And in right colectomies, the median length of stay was actually a day shorter amongst robotic colectomies. When we look at all of our individual morbidities studied, what we see is that in LARs, the robotic platform has a bunch of beneficial properties, namely a lower rate of superficial surgical site infections, a lower rate of wound dehiscence, a trend towards lower rates of transfusion requirements, however, a trend towards higher rates of readmission. There was no difference in the left colectomy group, and in the right colectomy group, there was actually a higher rate of renal failure amongst robotic right colectomies. When we look at our adjusted outcomes with our logistic regression, there was no difference in mortality, although the confidence bands are wide because there are a few cases where patients died. No difference in overall morbidity, although trends towards decreased overall morbidity in the robotic group. Sorry, laparoscopic colectomy serves as a reference for all these odds ratios. And no difference in serious morbidity. When we look at everything as a whole, all of the different morbidities that we studied, these are the only ones that are significant here. So conversion rate to open is decreased in LARs, in robotic LARs, and in robotic right colectomies. The rate of diverting ostomy is significantly higher in robotic LARs, and the rate of postoperative sepsis is significantly decreased amongst robotic LARs. In discussion, robotic LAR compared to laparoscopic LAR is associated with several improved outcomes. Those lower conversion rates to open, lower rates of sepsis, shorter mean length of stay. However, it's associated with an increased rate of diverting ostomy. The reason for this relationship isn't entirely clear right now. Very few papers have studied that relationship, but that relationship held true if we only analyzed patients undergoing LAR who had cancer and received preoperative chemotherapy, and they were identical in their distribution of cancer stage. So it's unclear whether this is surgeon factors. Perhaps surgeons who perform robotic LARs are more likely to divert their patients if they were lower tumors, which this data set does not capture, or potentially there was more positive leak tests that drove surgeons to perform diversion. Robotic versus laparoscopic left colectomy is overall similar, with a 40-minute longer operative time in robotic left colectomy, but a shorter length of stay. And robotic versus laparoscopic right colectomy did have some differences, namely that lower rate of conversion with robotics. Now, I mentioned that this is potentially spurious as the rate of conversion, unplanned conversion to open, was lower in laparoscopic left colectomy than laparoscopic right colectomy, which causes me to question whether there were less experienced minimally invasive surgeons performing laparoscopic right colectomy that were performing their lefts and LARs open. There was a longer operative time with robotics and a one-day shorter length of stay with robotics. Now, this is a retrospective review. There wasn't consistent data on oncologic outcomes, so I didn't present that and couldn't analyze that further. And the baseline differences in operative indications may bias our results, although we did our best to control for that. So robotic LAR is associated with several advantages that we've outlined. Robotic left colectomy, really similar outcomes to laparoscopic left colectomy, and robotic right colectomy with that decreased rate of conversion and decreased length of stay. I appreciate your time, and I'm happy to take any questions.